The title would be the topography of the neck, and we can divide it into the following. So just title, topography graphy of the neck. And we, in our illustrated anatomy, will do the same as I did it in the morning for your Czech colleagues. So starting first of all with some general information. First of all, discussing the orientation points or palpable points in the neck. Are there some typical points? Definitely, maybe that better would be to start before we will start with the review of the points. We can look at the regions again. This diagram shows the regions of the neck. The boundaries would be, as you see, mentum along the whole mandible to the exteracoustic meatus and protuberantia occipitalis externa. Ventrally anterior is the median plane, and caudally is the clavicle, the jugular notch, clavicle, acromion, and then dorsally, but this is in fact the thorax, C7 vertebra. No, the regions are in fact, or could be called the superficial regions, because as we remember from the head, which was more complicated according to the fact that we divided the regions into the superficial and deep ones. Here we don't have practically the deep regions. We have deep spaces, and as we will see in one of the first drawings. But the regions are quite clear. When we look at the anterior margin of the trapezius, so trapezius, I'm using very thin red line, so I will draw similar diagram. So from this line, dorsally posteriorly, this is not the neck. This is the nuchal region. This is the back. So note that all the regions in front of this line are called regions of the neck, but dorsally to this line, to the anterior margin of the trapezius, all of them are dorsal, posterior, or back regions. Concerning the orientation, the next important structure, which is also palpable, is the sternocleidomastoid. We see the relief of the sternocleidomastoid, and sternocleidomastoid muscle divides or subdivides the regions into the anterior part, anterior triangle, the big ones, and the lateral triangle, lateral region, lateral triangle. Then anterior in the median plane passes from the tip of chin through the midpoint of the hyoid bone, through the laryngeal cartilages to the central point, which lies in the deepest part of the jugular fossa. The regions are in fact called also triangles because they are the submental triangle, submandibular triangle. Here, the region, because this is called also anterior region, could be divided or subdivided into the hyoid region, laryngeal region, then thyroid region, and tracheal. Then follows the sternocleidomastoid region and lateral triangle lateral region, which is also divided by the course of the omohyoid, dividing it into the omotrapezoid and omoclavicular region. So this is just the short review of the structures. Palpable structures are, of course, the whole mandible, including mentum. Then palpable is also small depression, in small depression the hyoid. Then laryngeal prominence, which is bigger in men. Then jugular fossa. Then the relief of the sternocleidomastoid, and in some cases also, in case of enlarged thyroid gland, which is called struma or goiter, then we can palpate also the goiter, the struma. No? And if we look at some superficial structures, this is one of the diagrams. Definitely we have more. So you see that there are some laminae of the fascia. We will draw the diagram. Here you see that laryngeal prominence, jugular fossa, superficial nerves, superficial veins. So first of all, starting now with the palpable points, orientation points, or we can call it also landmarks of all the regions, better, of the neck. First of all is the sternocleidomastoid. We said that this muscle mastoid represents in its key position the oblique line dividing the regions into the anterior triangles and lateral triangle. Correct. Then we see the laryngeal prominence. We said laryngeal prominence is the prominence of the thyroid cartilage, and bigger, definitely bigger in men, symbol of Mars. Okay, cartilage. Then next one is the hyoid, definitely hyoid bone. Then jugular fossa, and because this is also important, a landmark, and in some cases enlarged, we could say struma or goiter. If you look into books, so this is the thyroid enlarged gland, thyroid gland. Fine. Concerning the subcutis in general, again, in general, what we see in subcutis? No, subcutis represents the area where we can see and palpate also the fatty layer of different thickness. So we could say that anteriorly, they are, as we have seen, the veins. Anteriorly are the veins. We call them venae jugulares or anterior jugular veins. We'll repeat both names are venae jugulares anteriores, or we could say anterior jugular veins. They have the connections with and for the connections, again, using blue, we will draw these arrows, the connections with the external jugular vein. I will draw diagram, simple drawing, external jugular vein. And the external jugular vein is important represents the important interconnection with the deep veins. So again, concerning the spread of infection, we see direct roots. So I can put below that spread, not spread logically, just possible way, possible roots, maybe even better, possible roots, possible ways, roots, okay, roots of infection or of spread of infection from superficial to deep and vice versa. Good. So these are veins. So anterior jugular veins, deep veins. They are just the last ones. Then, if veins, it must be also, okay, veins, correct, and the nerves below that in the same column. The nerves represented by we could say just the branches of cervical plexus. We said that cervical plexus innervates by the segmental branches, the occipital area, by ventral branches, the anterior area. We will see the neural point, nervous point of the cervical plexus. Maybe the best diagram is that one, where we see again the external jugular vein. There are some lymph nodes, definitely. And then here you see that there is in the midpoint of the posterior margin of the sternocleidomastoid, we see three nerves. One is transversus colli, one is auricularis magnus, great auricle, lesser occipital, ascending to the occipital region to the auricle. And then the inferiorly run three branches or three complexes of branches, because there are more branches, because supraclavicular innervate the upper part of the thorax, are now at the level of the clavicle. That's why we call them supraclavicular. So all these three, or better four branches, they originate from this point, and we call it the punctum nervosum, or neural point, or nervous point of the area. So cervical plexus, and at the moment, because we will draw it in the sternocleidomastoid region, just we could add plexus from the neural point of the cervical plexus. All of them are sensory, so I just add that they are sensory nerves. subcutaneous or cutaneous or sensory. All these names are used. Fine. Occipital region is innervated also by the same plexus, but by segmental nerves. Then follow the fasciae and facial spaces. Facial spaces. If we look at fasciae and facial spaces underlined by green because there are fasciae, we could say that the fascia, we call it cervical fascia. We know it, just short review, consists of 3 laminae. Has the lamina number 1. We call it investing or superficial lamina, investing or superficial lamina. Okay, number 1. We will use the numbers for the drawing. The drawing is very simple. You already got it, so that's why I will not draw an extra drawing, just sketching lamina. Then number 2 is the pretracheal lamina, pretracheal, and just L. And number 3 is prevertebral. So there are 3 laminae, and we will see them. These 3 laminae represent an important area, or better, form the boundaries of the area of the spaces. We call them paravisceral and previsceral space. So look at the, or we are looking at the space. So we are anteriorly just drawing position of the platysma. We know that platysma doesn't have any fascia and lies few centimeters from the median plane. Then follows using directly green color. Here we see the first lamina, which encloses also the muscle sternocleidomastoid. Then follows the second lamina, enclosing the infrahyoid muscles, as we see, and surrounds the organs. Organs here. This is the second one. I will describe and label all of them. Then we know that there is the complex of the organs. This is the thyroid gland with isthmus. Then the trachea, using blue for trachea. Anteriorly, yes. Posterior, there is the muscular wall, and then part of the esophagus, the dark one, and maybe that it could be colored by different color, like half of correct. Thyroid gland. Now, what do you think to use oblique hatching in orange? If we have these 3 structures, why not to add 1 black dot, which is the recurrent laryngeal nerve, from vagus. Recurrent laryngeal nerve is from vagus, definitely. Then we are looking also at the organs, so then trachea. Then this one is isthmus, narrow part, isthmus of thyroid gland. Then here the muscles are infrahyoid. We will speak about them. Infrahyoids. Then sternocleidomastoid. Master abbreviation is sufficient. Muscle, correct. Platysma, we said. Then here we have the this is the esophagus, so esophagus, quickly. And then if the gland, here is the parathyroid gland. Why not parathyroid gland? Sorry. We have now the whole view. And then finally, we need also the prevertebral lamina, which runs dorsally. They probably fuse dorsally together. Here we are drawing muscles, plus here must be duplicature of the And here in this duplicature of this prevertebral lamina must be the sympathetic trunk. All these structures, sympathetic trunk, will be discussed again in the specific regions. But here we need the spaces. Anteriorly, there are the anterior small vessels. They are called anterior veins. These are the venae jugularis anteriores. These are those veins. It's not bad to add anterior jugular veins, then veins belonging to the thyroid gland. So we could say just thyroid. Why not? Not so much place. Thyroid veins sufficient. Everything's quite clear. And then here, drawing two deep muscles, we call them prevertebral and scalenine muscles, just labeling them prevertebral, vertebral muscles, deep prevertebral muscles. There are only two, and finally the vertebra, like that. We could be at vertebra on number C6, C7, could be C6. Why not? Okay. No, and in the lateral space, we see the segment of this trachea. So the numbers. Number one is investing. Number one. That one is number two, pretracheal, and the last one is prevertebra. So we 1, 2, 3, all three laminae of the fascia. The vertebra must be in yellow, and here is also the vertebral artery inside, but doesn't matter. This is correct. So we have three fasciae, three spaces, which show or which are situated between the fasciae. Consider the fascia. Important point is that the fasciae limiting the spaces are also important factors that can reduce the spread of infection. You see, this is also very important to know that what we know, there is could be spread of infection in vertical direction, descending, for instance, even to the paravisceral space deeper. So the spaces, as we see, are the previsceral. So just spaces. We could use here we have to add also the artery, vein, vagus dorsally posteriorly, and ansa. This whole complex is called carotid vagina. You also remember from carotid vagina of from the previous diagrams, but this is just last review. Consider the spaces using which color, maybe dark red. The space here in front of the organs is one cross, and here are the other crosses like that. The first one is called, of course, sometimes it's mentioned also, that one is called previsceral, and that one is paravisceral, visceral space. That's it. No. So and finally, that one is retrovisceral, retroesophageal. Why not? Maybe also we can add also one more, maybe just big dot. Yes. And this is retrovisceral. Why not? Retrovisceral. Correct. So we did the best for the drawing. So we know some landmarks, then the fascial spaces. In the next paper, we would mention just few words concerning the importance of the anatomy. Also, we have to know that through the neck, or in or through the cervical regions are GG. run or descend the following structures, organs, etc. Which ones? No. First of all, in the first position is carotid vagina. Yes, we know that carotid vagina. I'm drawing now this carotid vagina, which consists of, we will not repeat it again, just looking that this one will be medial orientation, then posterior direction, and we said that medially, internally, there is the common carotid artery, laterally, this jugular vein, posteriorly is the vagus, and anteriorly ansa cervicalis. So in the first position, definitely carotid vagina, because it contains important structures. Here is the vagus nerve. Here is the ansa cervicalis. We said that ansa cervicalis, and I will repeat it again, profunda, deep ansa, profunda is the ansa, is the loop, which consists of the segments C1 to C3, and these segments innervate the muscles. We call them infrahyoid muscles, muscular branches. Laterally is the internal jugular vein, deep vein, sorry, and dorsally, posteriorly on the surface lies the chain of the lymph nodes. We could say chain of deep cervical lymph nodes. We will see them again. No? So this is one structure, carotid vagina. Then in the second position, this is number one. Number two, we remember that through the neck ascend four arteries supplying brain, and also plus orbit, and the other organs, sense. So which are the internal carotid arteries, internal carotid, we could say carotides, internal carotides, and also vertebral arteries, and everyone knows that all these join together, forming on the base of brain the arterial circle, circle of Willis. We will remember this name, Willis's arterial circle, circus arteriosus. Done. The next structures are the carotid body or carotid sinus, and carotid body. What does it mean? The structures are situated in the neck. We have to draw simple sketching, no, only that one, looking at the common, this is the common carotid. We are looking at the common carotid artery. If we are at this level, this is level C3, C4, skeletotopically, and this is the level where lies the bifurcation. We call it bifurcation of common carotid artery. Coloring this artery, we could use light red like that. Coloring also the first ever branch of the external, because this is the internal. The other one is external carotid, and darker red colors the carotid sinus. So here you see the carotid sinus, and using black dot, here is the carotid body. Maybe that this arrow is quite clear. To this body and sinus descend two nerves, drawing both of them. This is 10 and 9. So vagus glossopharyngeus plus the plexus around the all the arteries, because we call them periarterial plexuses. So we could add here, maybe on this side, that thin lines indicate the periarterial sympathetic plexus. Sympathetic plexus. Good. So repeating, these autonomic nerves that innervate these two structures, and I'm repeating, carotid sinus, this is that wall, and carotid body, glomus, because glomus caroticum, glomus also is used. So these nerves come from vagus and glossopharyngeus, which could be colored by, no, why not dark red? Both of them, dark red, are the parasympathetic. They are parasympathetic, and orange color could be the sympathetic periarterial, and this is sympathetic. So there are two types of the fibers, static or neurons, and both of them belong to the autonomic nerves. We speak about these nerves because, or according to fact, that these nerves innervate. Number one, in the carotid sinus, they are baro or receptors, baroreceptors, controlling the blood pressure. And in the glomus caroticum, in glomus are the pH receptors, and these pH or chemoreceptors, we could say also, they control the quality and blood pressure, quality of blood, level of pH, that means CO2, not oxygen, because this is the indirect, and also the blood pressure. And these autonomic nerves send the information to the concerning blood pressure and pH of the blood. So they send the info to the medulla oblongata. We remember that medulla oblongata represents the brainstem. In the medulla oblongata is the cardio, that means into the cardiovascular center, which is situated in the formatio reticularis. Now we can just put the name reticular formation. It's too early to discuss and explain reticular formation. Just to say, sufficient to say that the reticular formation consists of the network of the neurons that form the centers, like the cardiovascular center of the respiration, etc. So these centers are situated in that network of the reticular formation. Very important. No, and then this was number 3. Number 4, and we run to the end because we have to say also some words to the review of the muscles found in the neck area. Very important are the nerves number 9 and 10 plus 10, which are also found here in this sinus, but they innervate also, I would just say, innervation of and then number 10 of larynx. No, better is to say both of them of the pharynx, right? Pharynx, and vagus also larynx, plus nerve number 11, because also 11 sends the internal branch to larynx. So again, innervation of the larynx, yes, and both of them pharynx. No, this is quite clear. And the last structure passing through the neck, there are more definitely, but I'm just defining few. There is the phrenic nerve. Everyone knows that phrenic nerve with segment C3, mainly 4 and 5. This phrenic nerve passes through the neck. Descends, I would say, descends to diaphragm, and repeating that it has the motor as well as sensory part, sensory fibers. Usually we use the word sensory fibers or neurons. That's it. So these are the very important structures found in the neck. No? And then a short review of the muscles. So we could say muscles of the neck, and repeating just short review, because we don't have time to spend the whole time with the muscles. We know that the muscles have different origin. Can be, yes. So concerning the muscles, they have different. They are of different origin. We know that origin means also based on the innervation of the branchial arches. We remember that definitely the arch. The first one is innervated by trigymnus. The second one is hyoid, innervated by nerve number 7. The third is innervated by nerve number 9. So this is what we remember. A different origin, course, innervation. Is better to say if they have different origin, so it means that they develop together with the nerves, so with their nerves. So that means the also innervation is different, each group. Then function also different, action, function or action, as you wish. Fine. And we are looking position also. We are looking at the position because this is the simplest classification. So starting with the layers one by one. Number one is the platysma muscle. Maybe that we can start first of all with drawing. Why not with one drawing or two drawings from a Gray's Anatomy? Maybe that this one will be sufficient. We are some because this is, we can reduce reflex. Of course, what we see is the platysma. Fine, platysma crosses the mandible, originates from the level of the first, second rib, and then ascends. In fact, is attached also to the fibers of the depressor labii inferiors and depressor anguli oris. Behind that, covered by the fasciae or laminae of the fascia coli, are the other muscles. So we see them. Yes, there is a group of the suprahyoid muscles. There are 4 in number. They are attached to the hyoid and elevate the hyoid. Together with hyoid, also the pharynx and larynx during deglution. That means during swallowing. They are those that elevate the mandible. Then the anterior belly, for instance, they pull the hyoid anterior, the other ones posteriorly. Then follows the group of another 4 muscles. You see the longest one is that omohyoid, originating on transverse ligament of the scapula, the inferior belly, and then is attached to the hyoid. Then the more medial is sternohyoid, but the longest one is the omohyoid, definitely. These muscles, they are responsible for depression of the hyoid and also depression of hyoid, or also they cooperate in the movements of the larynx, pharynx. Then follows the biggest muscle, the strongest muscle in this group. This is the sternocleidomastoid, attached to the mastoid process. The muscle divides the areas of the neck, as we said, into the anterior and posterior triangles, or lateral triangles is even better. Here you see the anterior margin of the trapezius. This is the borderline separating the groups of the muscles, or even the regions of the neck into anterior and posterior in the back. And then follows the group of the deep muscles. Better is the diagram on the opposite side. We see again here, by the way, here's the internal jugular vein. Then we said that this region is anterior region of the neck, which is subdivided into the hyoid region, the laryngeal region, glandular or thyroid region, and tracheal. So it's not bad to repeat. Here we see the supraoid muscles like digastric, hyoid, etc., stylohyoid. Here we see the sternohyoid, then omohyoid, then sternothyroid and thyrohyoid. These two. And then posteriorly, dorsally, we see the group of the deep muscles. Laterally are three muscles called scalenii muscles, musculi scaleni, anterior, middle attached to the first rib, posterior attached to the second rib. They are responsible because they originate from the transverse processes of the cervical vertebrae. They are responsible for the lateral flexion, for the flexion, and also very important action is the formation of the fissure between them, and through the fissure run the vessels, the artery, subclavian artery, brachial plexus. In front of that lies the vein. We will see diagram. And also they elevate the ribs. That means they assist in the inspiration. They are inspiratory muscles. While the last ones, the anterior group, longus capitis and longus colli, these two muscles, in fact, originate the longus capitis from the base of the occipital bone, and then descends to the transverse processes. From then around the longus colli, and these muscles are responsible for flexion. They are also situated in the deep or the closest proximity to the vertebrae. So I mean that this is sufficient for the information of the muscles. So platysma is number one. In each muscle, we would say just very quickly some characteristics, but what is more important is the innervation. So maybe that we can put here number 7, because this is innervated by nerve number 7. It crosses platysma with, it doesn't have any fascia. Maybe that we could say just that platysma ascends from the rib 2, from the second rib up to the and crosses mandible. The fact that is innervated by nerve number 7, it means that belongs to the muscles of facial expression. Is sufficient, absolutely sufficient. The second muscles, but the group of the muscles, are the suprahyoid muscles. Yes, these muscles are 4 in number. They are different innervation because of different origin. So we will name them. The first one is the mylohyoid. Mylohyoid, as we remember from the description of regions of the head, it forms the floor, just we could say floor of mouth, or better floor of the oral cavity, innervated by the trigeminus, because it belongs to the first arch. So cranial nerve number 5/3, mandibular. Of course, the nerve is called mylohyoid nerve, easy to remember. Fine. Then second one, B, is the digastric muscle, digastricus. It has superior belly, not superior, is omohyoid. Thinking, being in advance with thinking, yes, this is the anterior belly. This anterior belly, better handwriting. I had one lecture from 7:30 to this will be very early for you. This was for students studying in Czech. So must be again improving. Anterior belly, correct. Anterior belly is better now. Is innervated again by the same nerve. It means mylohyoid nerve. And venter, posterior belly. These bellies will be described in the submandibular trigon, so it doesn't need any extra comments. Number 3 or C, just by the way, because posterior belly, I haven't mentioned posterior belly, which is mistake. Posterior belly is innervated by nerve number 7. So we can call it also, this is the diplo in medical terminology. We use the word diploneural muscle, diploneural, because different bellies, different nerves. The third one is the stylohyoid. Stylohyoid is the muscle which descends from the styloid process attached to the hyoid bone. Easy to remember, innervated also by nerve number 7 in the same group, no? And D, the last one, is the geniohyoid. Geniohyoid is the muscle which lies on the mylohyoid muscle, so forms also the floor and is innervated, take care, by nerve number 12. This is hypoglossus. So hypoglossus innervates the muscles of the tongue. The third group are the muscles, they are brothers, in fact, we call them infrahyoid muscles. Infrahyoid muscles, and the infrahyoid muscles are innervated, which is easy to say at the moment, by segment C1 to C3, ansa, by branches of ansa cervicalis, ansa cervicalis profunda, and we will see the ansa cervicalis profunda. Maybe why not to draw cervicalis profunda? There are segments C1, C2, C3 segments. They join together, and I would preferably use the nerve number 12 in yellow. So the ansa, this is that ansa with the superior radix or root, and that one is inferior radix or root, part also, both. And this ansa gives off the branches to the geniohyoid, as you see, geniohyoid, nerve number 12. It runs, it runs together with nerve number, this is not correct. It has 4 branches, you see them, and all these branches run to the group 2, because group 3. Sorry, infrahyoid muscle to group 3. Fine. So we have the third group, ansa. That's why we call it ansa cervicalis profunda. Fine. The muscles are as follows. The most important for the orientation in the group is the omohyoid muscle. The omohyoid muscle has superior plus inferior belly innervation, slightly function, elevation, or better depression of the hyoid, and together with the hyoid also is the depression of the pharynx in the swallowing. Yes, also helps to form the boundaries of the carotid trigon. No, doesn't. So is sternohyoid, the most medial muscle. Omohyoid, I haven't mentioned, it runs from scapula, scapula, correct. Sternohyoid, from sternum to hyoid, running anteriorly, superiorly. This is not necessary to say anything. Then the next one is the there must be the sternothyroid. It runs from the thyroid, sternothyroid, from sternum to thyroid cartilage, correct, sternum cartilage, and the last one is thyrohyoid, which is the continuation of this previous one. So again, from cartilage to hyoid. You see, in fact, two of them form the same muscle. No, and then number 4, we are at the sternocleidomastoid, which is the muscle that is strong one. We know that the muscle is responsible for movements of the head, is innervated directly by nerve number 11, accessory nerve, and it's situated within the superficial lamina of fascia coli, we could say, fascia coli. On the back side is the punctum nervosum, as we said. So punctum nervosum, the sensory nerves point, and it's the movements are the following. It's elevator of head raises, or by elevator raises head is more simple. Superficial lamina, yes. Raises head, one thing. Then responsible for a torsion to opposite side. Then muscle of inspiration, because it helps to elevates, because sternocleido, running from sternum and clavicle to sternum and clavicle are attached by the ligaments, the ribs. So that's why sternocleidomastoid helps also, or assists in the inspiration. Good. Then finally, there are two last two, 5 and 6. No good. 5 are the scaleni muscles. This is anterior, middle, and posterior. We could say that anterior, middle are attached. I would say attachment, origin or attachment to the first rib, and the posterior to second rib. They are muscles of inspiration, and also responsible for the bending. So lateral flexion, then also flexion anteriorly, and also torsion definitely. Attachment first and second rib. And we could say that scaleni muscles are innervated by the ventral branches. Scaleni, we could say ventral branches of cervical nerves, innervation, all of them. And between them, using which color? This one, between the anterior and middle, there is the fissure. We call it interscalenic fissure. We will draw the fissure again in the last region, the scaleniovertebral, but we can see the fissure. 1 second. Here we have an extra diagram from one of our books. Here you see the scalenus anterior middle scalenus, posterior is attached to the second rib, middle and anterior to the first rib. And you see that between the anterior and middle is the fissure called fissura scalenorum, an interscalenic fissure. And then on the floor of the fissure lies the subclavian artery. And above that are three trunks of the brachial plexus. And then quickly in front of the anterior scalenus lies also the subclavian vein, and phrenic nerve descends on the scalenus anterior. So we will draw the diagram just to know that scalenic fissure, and it contains the subclavian. We can just put here two names: subclavian artery, brachial plexus, just to know that the structures pass through this fissure, not in front of, because this is the vein. So I mean that this is quite clear. There is the interscalenic fissure, which contains subclavian artery, not vein, and brachial plexus, three trunks. That's it. And this is number 5. And then the very last one is number 6. Scaleni, we said muscles of inspiration, correct. And number 6 are the muscles called deep muscles of the neck. Deep muscles of the neck. Yes, and there are two only. This is a longus capitis, and longus colli. B longus colli, longus capitis, longus colli. Longus capitis descends from base of skull, to from base of skull to vertebrae C3 to C6. It's not necessary to remember all these facts, but just for better orientation. And longus colli descends from bodies of C2, C5 to thoracic vertebrae T1 to T3. No, and again, these muscles are situated on the anterior side of the neck, so that's why they are responsible for flexion, mainly for flexion. No, just to know the nerve supply of all of them. Again, ventral branches of cervical nerves, sufficient, absolutely sufficient. No, and when we speak about the muscles, we have to say also some words to the nerves. So very quickly, short review of the nerves, because we remember from the introductory lectures where you were informed about the innervation. Just to say, nerves of the neck regions, or cervical regions, are GG plural. And just to know that there are in fact more sources of the nerves. This is not only one category. We start with category A, which are the spinal nerves. Yes, we know that spinal nerves. We will not speak about the test. This is absolutely not necessary. They form plexuses, but not all of them, just ventral branches, and then the spinal nerves, underlying it by orange. They just quickly, we see the segments C1, C2, C3 on one line, C4, C5, C6, C7, C8, and T or TH1. Yes. And then the segments are interconnected, as you see, forming the plexus. And these four, from C1 to C4, form the cervical plexus. And we use the word many times, cervical plexus, with the punctum nervosum, neural point, etc., etc. Cervical plexus, C1 segments to C4, correct. Then the other ones join together, forming three trunks. You see, they are trunks. They pass through the interscalenic fissure, and these trunks That means C5, C5 to T1 forms the brachial plexus. Brachial plexus doesn't supply the nerves or muscles of the neck, but they pass through the neck. And the spinal nerves contains the fibers or neurons. You can see also neurons, fibers. We would use from now onwards always these three colors. First one are the sensory using blue, then motor. So sensory for the skin subcutis, preferably using light blue in our diagrams. Then motor would be in red, motor branches for the muscles. I would say skin, etc. They are muscles. And finally, the third one, just light green, and they're autonomic. Autonomic nerves. We remember that autonomic are divided into the sympathetic, which are situated and here, and parasympathetic, using just used it several times. These two types were already explained. No, and very quickly, the plexus, the cervical plexus, because this is that one supplying the nerves, and they form the punctum, the Latin word, neural point, which innervates. We can use also, why not, Latin, punctum nervosum. You can read it in the books, so why not to use both? So neural point, which lies behind the sternocleidomastoid, and it sends 4 nerves. So we know them. We will not repeat them. Then form also must be another arrow, that one. So neural, we see another thing. That means ansa cervicalis profunda, because this is the ansa supplying the infrahyoid muscles, we said. And also very important nerve, the phrenic nerve. Everything descends from the cervical plexus, phrenic nerve. We said C3, 4, and 5. And concerning the categories, neural point 4, sensory nerves, ansa with the motor branches, and take care, the phrenic nerve has both sensory as well as motor. So motor preferably. Then, so first category, spinal nerves. Then category B are the cranial. We already mentioned that the cranial nerves, represented here by the nerves number. And look, this is number 5/3. We know mylohyoid, innervating the anterior 2 muscles in the region. In head is quite clear. This is the muscles of mastication. Then number 7, yes, the muscles, which is number stylohyoid and posterior belly of digastric. So also we said and mentioned. Number 12, hypoglossus, innervating geniohyoid, we said. And also the other muscles, which is number 9 plus 10. We said these are autonomic nerves innervating the organs. And also nerve number 11 is the sternocleidomastoid. So 11, no, not necessary to write. So we know that these all muscles are muscles belonging to the cranial nerves. No, and the last one is C, is called cervical sympathetic cervical sympathetic nerves. Very important part. I would like to show you that the sympathetic sympathetic nerves forming the sympathetic complex. We see the sympathetic ganglia. There are 3 ganglia. The last one is situated below the subclavian artery. So if you look at the diagram, we see the hyoid bone, thyroid, cartilage, trachea, then transverse processes, ribs originating here. Then on the right side, this brachiocephalic trunk dividing into the subclavian artery and common carotid. Look that the ganglion, the medium and inferior, or ganglion inferius, are interconnected by this loop. We call it ansa. And then you see the chain of the ganglia. We know that they are ganglia situated on both sides of the vertebral column. 1 to 3 ganglia, also accessory ganglia concerning the renamed and cervical ganglia, and then follow the thoracic ganglia, lumbar ganglia, sacral ganglia, and ganglion impar. Note please that there is on the surface of the aorta, also on all the arteries, the plexus. We call it a sympathetic plexus, periarterial. And as we said, the periarterial plexus is the plexus of the sympathetic fibers that reach their target organs via the vessels, like the plexuses, like the periarterial plexuses. No, this will be sufficient. So we have to say some words, because the cervical sympathetic nerves, although we know that this is, we do the best to show you the most important things, and this is a little bit more in advance. I fully understand it, but what to do? First of all, drawing 3 ganglia, and we call them 3 ganglia cervical, right? Cervical ganglia, superius, medium, and inferius, ganglion. This is neutrum, ganglion inferius. But the third one is called cervical, is identical with the name cervicothoracicum, cervicothoracicum, or stellatum. Stellatum means like an asterisk. Fine. Then they are 10 to 11 thoracic. Then usually 4 to 5 lumbar. Then usually 4 sacral, small sacral, and 1 for sacral and 1 coccygeal, called impar, also called impar. So simple sketch on the next page. A simple drawing. Look, drawing 2 chains of the ganglia. First of all, the ganglion, I will just put superior cervical, that's it, and ganglion. Then they are interconnected, definitely. Then is the medium, ganglion medium following, and of course interganglionar fibers. Then the complex of the nerves, or the interconnections, etc. is complicated. We will see. This ganglion lies at the level of usually C2 to C4. That's why it could be variable in position. The medium usually at the level of C5, and then follows. Take care, drawing on both sides, definitely, but only on one side I will describe it. Drawing here subclavian artery, subclavian artery. So, and then the middle ganglion, GGL, runs around, forming the ansa, interconnecting the next, like asterix, stellatum, which has more fibers, and this is that stellate, or cervicothoracicum, ganglion. Fine. This ganglion could be found usually at the level of C7, usually C7. Fine. So we see the ganglia, and then follow the thoracic, as we said, and then the thoracic then follows the lumbar, thoracic, lumbar, etc. Right? And then finally interconnections, and finally there is the ganglion, impar, and also interconnected with the contralateral side. This is of opposite side, sufficient. Why we speak about this ganglia, why it's important is not, definitely it's very important, because we could say in general that the ganglia send the fibers, the neurons. Each of them sends the fibers to the heart and also the other organs, definitely, because they run via the plexus around the arteries, periarterial plexuses. And we could say that the fibers which run to organs, fibers run to organs via the periarterial plexuses. Are only plexuses, and they are only sympathetic. So only sympathetic, because parasympathetic run separately. That's very important. And we call these fibers visceromotor. In fact, they are descending. They are like motor, but not motor to the muscles, the skeletal muscles. They run to the muscles of the viscera. That's why visceromotor. So they could be colored. The arrow could be colored by red because they are descending. But together with them, with these fibers towards the spinal cord, run also viscerosensory fibers. And viscerosensory fibers transmit, because plural, transmit the visceral, mainly pain from organs with the wall made up of the smooth musculature. This is the rule. So the fibers, that's very important, fibers run in both directions. Together with this motor run also sensory. So you see, they must run in both directions. Then concerning the ganglia, very quickly, we don't need any long description. Ganglion number 1, superior, middle, and then cervicothoracicum, CT, and the ganglia. Just put some words to each. By the way, this one moment, we need different color. We said we could use different color, maybe that one. This one, that one, and that one, all of them, all these are called the cardiac nerves. So CN, and I will put here CN. These are cardiac, cervical nerves. These are nerves. Looking at the terminology, parasympathetic fibers also run to the heart, but we call them branches. That's why there is also difference. So concerning the ganglia, quickly, one ganglion, first one is S. No, S means that we know the level, and very simply, very quickly, the fibers, the first one, superior fibers, I just put arrow, run to the larynx, pharynx, definitely, larynx, pharynx, then heart, because they are the cardiac nerves, then have the interconnections with many nerves, but just basics with the with the nerves, cranial nerves number 9, number 10. Then they sent the fibers to the middle ear cavity, Then the fibers run to the nose, nasal to nasal cavity. We call it Petros part, but this is sufficient. Then to ganglions, to ciliary ganglion. No, ciliary ganglion is situated in the eye, and ciliary ganglion is situated in the orbit, and the fibers run to muscles, sphincter and dilator of pupil. And I will show you. I'm showing you the ciliary muscle. You see, ciliary muscle is the muscle which is responsible for the movements of the lens, and also the muscle situated within the iris. So they are responsible for the dilation or constriction. So we have to add that to the ciliary ganglion. Run or through the ciliary ganglion are the to the muscles, and then through the ciliary ganglion to the dilator of pupilla. That means opening the pupil through the ciliary ganglion, because the ganglion is small parasympathetic ganglion. And also they run the orbitalis muscle. No, when we see the inferior, you study now the bones of the skull, so we can put here inferior orbital fissure, or fissura orbitalis, inferior orbital fissure. So the fissure is bridged by the muscle. We call it orbitalis. This is that one, orbitalis, and also two muscles. We call them two tarsal muscles. Also, I will show you two tarsal muscles. They are situated within the lid, or lid, superior inferior lid, and we see it here, not that well, but is seen. Here is the levator palpebrae, and then from which descends the tarsal muscle, superior and inferior. So the bigger is the superior. Under tension of superior, it elevates the lip superiorly. No, and tarsal muscles, again, smooth. They are smooth, definitely. All of them are smooth muscles. And any damage, we would say paresis, that means damage, and in modified function, paresis of sympathetic nerves in this area causes the syndrome called triad of Horner. You will study it in the higher years, but doesn't matter. I would like to mention this triad, and which results in what? That means paresis of sympathetic, paresis of smooth muscles, leading to meiosis, narrow pupil, then ptosis, that means pending or depression of lid, of upper lip, and finally enophthalmos. You see how many new TH, enophthalmos, correct. Enophthalmos is depression, again depression of eyeball into the orbit, into orbita, into orbit. No, so there are many new words. It's not bad to learn new terms and then adding the new terms to your medical dictionary, medical vocabulary. No, this is all. There was a superior, then middle, very quickly, fibers to heart. This is quite easy. To heart, thyroid gland, parathyroid glands, that's it. And finally, the inferior, we call it cervicothoracicum, stellatum, again, the plexus is again periarterial, sending to the upper limb, upper extremity, and then also two very important arteries to the vertebral artery and also the subclavian. That's it. So subclavian artery. We completed the review of the nerves because we will remember better the whole situation in this area. So fine. So I mean that we completed everything, and we can start with the regions. First of all, the title could be a review of the regions. The next paper. I'm sure that you agree with me that these are very interesting topics, not that extremely complicated, maybe more easy than those in the head. Concerning the, we would say regions of the neck, regions of the neck, and looking at the regions, first of all, maybe that one drawing would be better as the illustration than long description. So we would look at the half. This is the best. Look, the best drawing, half of the regions of the neck divided by vertical line, median plane, then drawing the mandible, correct, from mastoid process runs, of course, ascends as the sternocleidomastoid. This is the clavicle, the sternocleidomastoid. The region divided also by position of the mandible, so quickly, this one, that one. Then from mandible ascending the digastric and also omohyoid, which passes craniocaudally, caudocranially, sternocleidomastoid. Then we see also anterior margin of the trapezius, and then the neck here as you see it, the half drawing. Fine. So concerning the muscles, this one we said using blue from this line, the area colored by blue is the posterior region, sometimes called lateral, but there is to say that this is the trapezius muscle, trapezius, and this muscle forms the boundary between the neck, this is the neck, and that one is the back. You see, that's very important. Of course, is a nuchal region. Fine. So forget the words that we are speaking about neck in this area. This is always the back. Fine. Looking at sternocleidomastoid, yes, we will leave it without any colors, just looking at sternocleidomastoid, mastoid would be sufficient. Then That one is omohyoid muscle, correct, omohyoid. This could be colored because it divides some regions in some subunits. Here is the hyoid, correct, and then digastric, sufficient, and the trigons. Then the trigons, it must be oblique in position. It's not bad, but better is to draw it like that. Okay, oblique. Anterior belly, posterior belly, so we see the trigons. First of all, that trigon is the submental. We will start with submental trigon. That one is called submandibular, submandibular trigon, also triangle trigon. Then dark red indicates the carotid trigon. This one is carotid triangle trigon, this one. Then anterior region is called regio anterior or cervical anterior region, so yellowish, must be anterior cervical region. Anterior cervical region is also called omotracheal because at the center distance trachea is omohyoid. Cervical region must be improved. Cervical region also omotracheal. Another word, omotracheal or muscular. You can read in the books muscular region, omotracheal, muscular. That's it. Also suprasternal, because also it descends to sternum, because here is depression. And concerning the general names, here is palpable jugular fossa, correct, one. And here is the another fossa, we call it major supraclavicular fossa, supraclavicular, and that's small between the origins of the sternocleidomastoid is called minor supraclavicular fossa. No, minor. Good. Concerning that last trigon, it could be even narrower, but doesn't matter. This whole trigon could be colored by different color. For instance, by the green one, and I would just use green for the lateral. This is called lateral triangle, lateral cervical triangle, sufficient, and this will be divided by the course of the omohyoid into two parts, but we will draw it in the specific area, specific region. So I mean that this is absolutely sufficient. So generally, the regions are divided into the anterior. In fact, anterior, they are all these to the sternocleidomastoid, so anterior, we will start with them, anterior regions. Then number two is the lateral region, lateral. Anterior is yellow, color white, red, all these are anterior. Then this one is lateral, anterior, lateral, and number three are the posterior, but posterior, of course, we can color them, why not? Posterior would be bluish, and I put it into the back region as the classification is back regions, because it belongs to the back regions. Anterior is without color. Here is bluish, anterior without. Then red, why not? And also the yellow. So these regions, you see how the colors can help. and eliminating abundant words, and then the lateral is green. So I mean that everything is very clear from this drawing. No, and we can also draw two lines, because here would be practically the boundary and another boundary. We see the superior, and that one is inferior. What? Superior. So we would say boundaries or lines separating, defining the neck. Superior boundary is easy to remember because this is in fact mandible. Just quickly, mandible. Simply, superior boundary separates the line separates the neck from the head. So mandible, external acoustic meatus, and finally the external protuberance, external occipital protuberance, not necessarily protuberance. Finished. And inferior boundary or line separating or dividing separating the neck from the trunk is easy. This is in fact jugular notch. That means handle or manubrium of sternum. Then clavicle, along some clavicle, and then acromion, finally cervical vertebra 7, spine of cervical vertebra 7. That's it. So we completed everything, and then we starting with the region number 1. Yes, number 1, framed by, no, what do you think? Blue. And starting with the anterior region, anterior region of the neck. Anterior region is, as we said, called also omotracheal, muscular, or suprasternal. All these names are used, so that's why we will specify them. Anterior region boundaries quickly, as we can use the symbol from hyoid, and manubrium of sternum, manubrium of sternum, sternal manubrium. Okay, sternum, and laterally infrahyoid muscles, hyoids plus sternocleidomastoid muscle. We can use this abbreviation. Fine. Without any long description, we are looking at the yellowish hyoid, then inferiorly the sternum and clavicle, then position of the sternocleidomastoid from the sternocleidomastoid and mastoid process sufficient. Then sternohyoid and omohyoid, they descend here. This is the omohyoid, which is attached, which originates from scapula. This is clavicle. Yes, could be also called by yellow. That's it. No, and then the only one descends. This is omohyoid. Yes, sternocleidomastoid, sufficient. And then look, please. We are coloring the sternocleidomastoid by some lines only, very light red. This could be also either without color. 1, 2. There are 2 muscles, as you see. One is sternothyroid, and one there is omohyoid. Sorry. So, and then these. Sorry. So it must be up. Yes, rolling up. And then using green, coloring the area by the fascia, because the fascia, the superficial fascia, encloses also the sternocleidomastoid, while the other ones are covered by the pretracheal. You see that? That's why I'm drawing 2 two fasciae. And then more important for us would be the position of the nerves, because here we see the arch, venous arch, arcus venosus, interconnected with many veins superficially and deep. The veins, as you see, also have the connections with the deep system. That's why I'm drawing small openings to show the veins. And these veins are also interconnected under the muscle with the vein that crosses the muscle descending, or also descending from here on the side, and having the connections with the anterior veins, and opening then either into the internal jugular vein or into the subclavian, both. So you see there's the perforation, and then it descends caudally. So the names are, this is the external jugular vein, external jugular vein. These are anterior jugular veins, anterior jugular veins, forming venous arch, arcus venosus, or venosal, or jugular arch, arcus venosus juguli. I'm using also the international name. And then here is the jugular notch. Why not? To add jugular notch, fine. And look at the, these are the interconnection, I would say, two deep veins. Is even better, two deep veins. And we also remember that this is a neural point without any color, without any branches, just add here one arrow saying that this is the neural point, or nervous neural point. That's it. Correct. No? So they are the structures situated on the anterior side. Very important to see and to know. No, and then as usually we start with the layers quickly, because not all the layers must be mentioned completely. So on the next page we have the layers. No, concerning the layers, we could say that they are in fact the same as in the layers, as the layers in the areas of the head, but the veins and nerves, in fact, anterior, are approximately the same. So starting with a thin skin, yes, it's definitely thin. Then follows number 2, subcutis. Subcutis. Concerning the subcutis, we know that subcutis contains platysma without fascia. By the way, we can also add contents. Why not immediately? Contents. And this would be even better to say that there is a larynx part of the thyroid gland, parathyroid glands, lower part of pharynx, part of pharynx, because we know that esophagus descends from C6, so then up to C6 there is also pharynx, part of pharynx, then trachea descending, then esophagus from C6, esophagus, dorsally, posteriorly, inferiorly, then lymph nodes, and the nerves plus vessels, as we said. We will see them in the layer. Okay, platysma. Then follows number 3, superficial lamina. I will not repeat once. Fascia coli, or also cervical fascia. Both terms could be used promiscuous. At the same level, we see the anterior jugular veins, anterior jugular veins, and and nerves, I would say cervical plexus, from cervical plexus, correct, nerve of cervical plexus, so nerves, veins, yes, then follow the muscles, we would say infrahyoid, infrahyoid muscles. Then follows number 5, pretracheal lamina, pretracheal, because they are involved in the pretracheal lamina, correct. And then follow thyroid under the pretracheal, in front of the pretracheal lamina follows the thyroid venous plexus, yes, venous plexus. We call it impar because it's unpaired, impar. I will show you also the thyroid gland. Definitely look here. We have that area. We see the hyoid bone, thyrohyoid ligament, membrane. Then follows the here covered by the gland lies the cricoid cartilage, and we see here the thyroid gland with the left lobe and isthmus at the center. Here is the remnant after the descent of the thyroid gland from the original position on the base of the tongue, caudally. Remnant is called thyroglossal duct, but sometimes in some, I don't know, in 30-40% of all the cases is the pyramidal lobe. Here you see the superior thyroid artery coming from the external carotid. Here is the inferior thyroid from the subclavian, but we don't see that branch of subclavian. They are just small interconnections. Here we see the veins. This is the must be also superior vein, media and inferior veins are seen here. We call them inferior or impar. And here we see the lymph nodes, pretracheal lymph nodes. And then dorsally posterior between the artery and vein descends vagus nerve sinister, nervus vagus sinister. That's it. So venous plexus, impar. Then at the same level is the larynx and descending trachea. And note please, very important, recurrent laryngeal nerve. We said that this nerve, laryngeal nerve, is the inferior from the vagus. Concerning the levels and correct position, we can say this is the skeletotopia. Why not to use that international word? Skeletotopic relation, skeletotopia. We know that larynx in fact is from C3 to C6, could be C4, 5 to C5, 6, but it could be also from C3, 3, 4 in. It could be also found. Newborn has different position. Number 1, larynx. What else? Then epiglottis. Epiglottis lies at the level of usually C3. Glottis is the depression bounded superior by the ligaments. I will show diagram. I will draw diagram. The glottis this contains the vocal ligaments, producing the vibration of the vocal ligaments, producing the tone. So this is usually C5. Hyoid lies usually C2, C3. Esophagus C6. No, that's it. So these are layers and also the contents of the anterior region. But as we said, part of the anterior region is also the suprasternal space. It should be mentioned, suprasternal suprasternal space. Suprasternal space is the space that lies anteriorly. We would color the space by yellow color, and the space is bounded by, or a distance from, the level of cricoid cartilage to the manubrium of sternum, just manubrium of sternum. Fine. And anteroposteriorly is bounded, this is craniocaudally, and anteroposterior by 2 laminae. So then you can add plus 2 laminae, but they are not seen craniocaudally, it's seen on the sagittal section. And we would draw the sagittal section. So we are looking at the sagittal or paramedial section, framed as usually by green or section. Yeah, this is really a sketch, but important would be the position of the vertebrae, this to lordotic, more vertical, this is better, fine. And we see the atlas, axis, first vertebra, second vertebra, third vertebra, fourth vertebra, fifth, sixth, seventh, and the thoracic, sufficient. First of all, we are drawing some connective tissue, soft connective tissue, which is important for the movements of each structure in such an area. Then follows the red line, sorry, one more line must be just too vertical, this too oblique, and you can criticize me that the position is not correct, and this would be bad. So this is much better now. Correct. So look, here's the soft tissue, soft connective tissue, important for the movements, because all the organs, or the hollow organs, they should be surrounded by the connective tissue permitting the movements, dilation, etc. So we are drawing now the line indicating the esophagus, and if we have 1, 2, 3, this is number 3, 4, 5, 6, from 6, distance esophagus, drawing esophagus, this is pharynx, right? Pharynx, esophagus, from C6 or from this line, doesn't matter. C6, fine. Here we have, and then drawing anteriorly, we know the epiglottis must be at the level of C3, okay, drawing C3 like that. Epiglottis closing, this is the larynx, as you see here, and the trachea. Again, here is the soft connective tissue, tracheal or esophageal cartilages of trachea. So this would be the trachea, anterior and posterior. We could say trachea, yes, trachea. In red, esophagus, sufficient. And then looking at the epiglottis, this is epiglottis closing the larynx. Then at this level is practically the glottis, yes. Here I'm drawing line, black one, like the depression. Where is the glottis? So no, note please that this is glottis, correct. And here at this level, approximately at this level, is the cricoid cartilage, and cricoid cartilage lies here. Then we can draw also the floor. This is the hyoid, etc. And then from the cricoid cartilage descend to laminae 1 and 2. I'm drawing wider, this is not that wide, the space, which are attached to the sternum. So here is the, approximately here is the sternum, coloring it by yellow. And the laminae are 2, thinking about the position of arrow. So this one would be pretracheal lamina. As you remember, it's a 2 laminae, fine. And that one is investing. This is the superficial. We would say investing superficial lamina. Okay, so we know the boundaries craniocaudally. This is the sternum, correct. And then we see the space. We said that the space should be colored by yellow, but before that, I am drawing the complex of small veins. So coloring it as the space. This is that space, yellow. Behind the space lies the behind the pretracheal, because pretracheal involves the structures like isthmus of, this is called isthmus of thyroid, thyroid gland. And then also this space contains the impar veins that open into the brachiocephalic vein. So we could add, no place, okay, brachiocephalic, improving a bit, brachiocephalic vein. No, this is sufficient, brachiocephalic, fine. So the main spaces are quite clear. Suprasternal, investing lamina, pretracheal lamina, sternum, then isthmus of the thyroid gland. And then speaking about some argent situation, I would say in case of argent situation, we know that it could be a blockage. I will repeat, blockage. In case of the blockage of air passages, airways or air passages, foreign body in larynx, So we know that especially children can inspire many different foreign bodies, like some balls, coins, etc. And then if it passes, is usually can block either this area, usually lower, below the glottis, and then blocking the air passages. What should be done? No, simply must be perforated the trachea, and then follows the foreign body, follow the following perforations. What to do? First of all, must be done coniopuncture using wider needles for intramuscular injection, even better, even thicker, coniopuncture or coniotomia. That means using something like knife. And this conio, I use the, which color? Maybe light red. This is the conio or laryngo, also laryngo. We can use the word also laryngotomia. Now more frequently used laryngotomia. So all these three, and using which color? Light orange would be A, in the position of A, which is here at this level. That means below the glottis. This is coniotomia A, or using different B color or B dark red, passing above this is B, or also C below the isthmus. So we call it superior or inferior tracheotomia. The tracheotomia is fully in the hands of surgeon, definitely. But coniotomia, the doctors can help or must help in case of suffocation, especially children. So to perforate the wall is very important because it prevents the suffocation, prevents the problems with the respiration. I would like to show you again one diagram from the atlas. We see three positions. Here is the conio, is a little bit lower, but doesn't matter. The coniotomia, conio is derived from the name conus, ligamentum conicum. The ligamentum conicum is the ligament between, do we see it? Yes, between the inferior surface of the thyroid, and then here is the ligament, and then here lies the cricoid cartilage. Is covered by the muscles and the gland. So here, because we can palpate it, like the cleft having 3 to 5 millimeters. So this could be in children is smaller. So this is called coniotomia. And then above the isthmus of the gland, or below the isthmus of the gland, the perforation of the incision of the skin, and then perforation is completely under control of surgeon, because there are many structures, especially in the inferior tracheotomia is complicated. So we know everything about that. I just put here tracheosurgery, right, because this is only possible to do in the surgery department. Correct. So this is the next one. So we completed the anterior region of the neck, including the suprasternal, important suprasternal space. Correct. Done. Then follows the it should be number two. Number 2. And we use the red number, and yes, framed by blue. It must be the same way, same format. The next region is called submental. Submental is easy. We don't need any extra drawing. Submental region, submental trigon also we can say, and just very simple sketch looking from below. Here we have the raphe of the mylohyoid, then the bellies of digastric. Here is the on both sides is the hyoid. So anteriorly chin, the raphe, and we could say that raphe, this is the same on the opposite side, raphe of mylohyoid, and immediately below that we can add that raphe of mylohyoid represents the direct perforating it from below, direct approach to base of tongue in case of tumor or any defect on the base of tongue. Sufficient, no? So here they are the anterior bellies of digastric, then chin, at the center is raphe, because you see there's a trigon that we can divide it into two halves. No, and then what else? Definitely the artery, submental artery and vein, just two lines on one side, and on the opposite side we can draw some lymph nodes, coloring by light green. So there's a asymmetry. You see, I'm drawing on one side one thing and the other one. This is the myelohyoid. So then finalizing in, these are called submental lymph nodes. And these submental lymph nodes drain, in fact, drain three areas: lower lip, of course, the central part, then tip of tongue, and also incisors, lower incisors. No, on first incisors. Here is a submental artery plus vein sufficient. So I mean that we don't need any extra text to this region. More important for dentistry, controlling time is good, is the submandibular. So submandibular trigone or area contains submandibular region or trigone also. The submandibular region contains more structures which are important for dentistry, like trigone, easy to remember, mandible, posterior boundaries, posterior belly, anterior belly of digastric. So I would just put bellies, belly, posterior belly, anterior belly, belly of digastric sufficient, and is the mandible, body of mandible. Fine. No, so boundaries, good. And then on one simple coronal section, what we see on coronal section, this would be easy, but we have to mention two things. What we need: mandible, yes, mandible and raphe, or line, myelohyoid line. Okay, like that. No, this would be too narrow. No, doesn't matter. Myelohyoid with raphe at the center, correct. Yellow for the mandible. And then drawing the gland. The gland is situated above because it lies behind. It lies behind the myelohyoid on the posterior margin. We see both sides, which are situated up and or above and below. Which color? Maybe orange would be good. Yeah, orange color. And then, of course, digastric lies here, digastric muscle. So here we see the raphe of myelohyoid, then digastric, anterior belly, digastric, yes, digastric must be improved, digastric, okay, muscle, fine. And then look at the, first of all, platysma, maybe brown color would be better. Platysma, yes, this is superficial muscle, and then the skin, like here, and then looking at the course of the artery. Note please that artery, I mean facial artery, passes through the gland surrounding the mandible, and the vein in blue passes in close proximity but not through the gland. So what we see here are in the submandibular region, the vein plus artery, facial vein and artery. Also we can draw here one of many lymph nodes. They are situated here and also in deeper, just lymph node because they are submandibular lymph nodes, important ones. Then what we see, of course, we have to draw also the it crosses the mandible, so the vein as well as the artery are situated on the margin. No, this is not absolutely correct. Must be a little bit higher, but doesn't matter. Doesn't matter. Platysma muscle is seen here. The muscle which ends at this level, joining the muscles. You know, the here would be, for instance, the depressor labii inferioris, for instance. So it ends at this level. No, good. Also, this diagram could show all the structures. Fine. No, and then they are also mylohyoid. The other vessels are not necessary to draw. Fine, finished. Concerning the layers, quickly, layers are quite clear. What we see is the number one is the skin, relatively thin. Number two is subcutis. In subcutis again lies platysma, plus vessels. Platysma is supplied. Look at the cranial nerve number 7 again, repeating superficial ansa cervicalis. We have mentioned it in the parotidomascetic region of the head. Platysma is innervated by cranial nerve, by ramus of cranial nerve number 7, connected with the transversus colli. So increasing contrast, this is nerve number 7. Here is the ramus colli nerve 7. This is the transversus colli, transversus colli, from the cervical plexus. So we remember that transversus colli from cervical plexus joined together, and we call it ansa, superficial ansa. That's it. So then one more thing is that number 3 follows the superficial lamina, and superficial veins. They are forming that arch, etc. And also we could draw the angle of mandible. Here we have the parotid gland. This is another drawing, not that one, because I would like to use space. And then if I would color the parotid by vertical hatching and horizontally transversally, so it's wrong. I have to make here a place, because otherwise everyone will think that this is the same drawing. Absolutely not. And this is one thing, fine, and this would be absolutely sufficient, cutting it. So I'm now thinking about the tract. We call it angular tract, tractus angularis, which lies at the same level or layer, and this angular tract separates the glands. The glands are situated in their beds, so separates the parotid gland and submandibular gland, right? Gland. So this separates both glands. Their glands in their beds, because the glands are situated in the beds. The connective tissue layer lining the beds. So this angular tract separates them. This is important because this sense the distance caudally, and separates means that limits the spread of infection. That usually these glands, if one is affected by infection, so the second one not. This is number 3. Number 4, submandibular gland, the biggest structure in this area. If I count them by orange, so I will do it. And this gland is situated close to the mandible in one small fossa. Innervated is not bad to mention immediately. Right now, that is innervated and innervation from the chorda tympani. We said in the last week that chorda tympani from nerve number 7 is the nerve that sends the parasympathetic, sympathetic fibers and also taste fibers, right? So important to remember. Fine. Submandibular gland plus the facial covering. You see, this is surrounded by capsule. In fact, this capsule or facial covering is better to say. And then follows number 5, which are facial artery plus vein, as we have seen in diagram. And then in the 6th position is important submandibular duct, submandibular duct, crossing plus lingual nerve, both together, lingual nerve. And I think I can just sketch again the duct, which runs like that superiorly, and then lingual nerve forming an arch here, like that, yes, passing under, above, ascending, and to the nerves is attached the ganglion. Yes, now we can complete the sketch here, the drawing. Here is the lingual nerve, yes, lingual nerve. Then duct would be in light green, yes. So you see that they are crossed, nerve runs under. And here is the submandibular, very important, submandibular parasympathetic ganglion, right, submandibular parasympathetic. Here is the duct, is in light green, this is the nerve. And discussing the chorda tympani, using what do you think about red? Chorda tympani, and chorda tympani descends, joining the nerve, running together to the ganglion, and also following the nerve to the anterior 2/3 of the tongue, because it innervates by parasympathetic fibers the glands, all the glands in the area, and also the taste. No, taste not. Taste is not. It passes through, but much better to say just glands. Also, not only the submandibular sublingual, but also the glands of the tongue. That's quite clear. This is number 6. Then number 7 is the cranial nerve number 12 plus accompanying vein, vena comitans. Comitans is official term. Vena comitans bluish with yellowish. In the drawing would be yellow and blue. No, nerve is motor definitely. And number 8 is the lingual artery. We will speak about lingual artery in the drawing. So I will show you the drawing, which would be very clear and very important for dentistry. Lingual artery. And then what else? A lingual artery can be dissected here, dissected and ligated when or ligated, yes, in case of bleeding, right, in case of bleeding. Finished. So lingual artery, very important, can be dissected and ligated. We will see in the forming diagram. No, this is the artery, we will draw diagram, and finally, next page is the, yes, it was number 8. So number 9 are the submandibular, very important submandibular lymph nodes, collecting the lymph from practically biggest part, largest part of the head. Yes, and that's all. So we need lateral view, drawing showing the lateral view. I think that it could be simplified. As usually, you can use all the atlases, all the good drawings, diagrams. The simplified drawings, as you see it here, they can help you because they are separated from sometimes complicated diagrams. So what we need the first of all digastric posterior belly, and above that lies the suprahyoid. So suprahyoid, yes, this stylohyoid, sorry, not stylohyoid, usually divides into two attachments. The posterior belly passes through, is continuous with the anterior belly. Here you see the hyoid, which must be shorter because it's the arch of body, and this is the posterior. This is the posterior, and maybe that this is absolutely not correct. No, it's correct, but not that clear. We need that cleft. Yes. So we see here again repeating. Here's the cleft, and then look, even better. Wait a second, because we need absolutely clear situation. This is the digastric. Here is that stylohyoid, and through the stylohyoid passes the digastric. Now it's correct. Yes. Fine. Colors. Posterior belly light brown, then anterior is light green, that central tendon, and then again repeating the fact that there is the stylohyoid with the direct attachment to the hyoid. And this is important because the digastric, in fact, is not attached directly to hyoid, right? But elevates hyoid and also pulls ventrally, while the posterior belly pulls dorsally posteriorly. Fine. So we see the outlines of the main structures. Then anteriorly runs the raphe of mylohyoid. So carefully we draw also the lines of the mylohyoid, like that, lines of the fibers. This could be sufficient, yes. So again, we see the mylohyoid, correct. Here is the anterior belly, belly of digastric, sufficient. This is the posterior belly, good. Posterior belly, fine. No, then raphe, yes, raphe, mylohyoid, raphe, definitely, and then is hyoglossus, but not necessary to draw like that. Okay, and then look at the position of the artery. So here I'm drawing the external carotid. This is what we see, external carotid, like that. And then the lingual artery, which ascends from the artery, the other branches. Then it goes up, passing between the posterior belly and greater horns of the hyoid, crosses the structures, passing through the space and ascending towards the tongue, to tongue. Yes, to tongue. Lingual artery, yes, lingual artery. As we said, the lingual artery passes through the space. Here we can ligate, dissect, and ligate this artery. So using different color, maybe that color would be good, or even violet would be even better. So if we are drawing using just, you see, using two lines, showing two lines, the angle here is called Becklard's angle. So the lingual artery passes in the Becklard's angle. So we could say ligature could be found in B, which is Becklard's angle, and this is not necessary to define the angle, because this lies between is bounded by the posterior belly and the greater horns of hyoid. H is hyoid, or also in Pirogov, in P, which is more complicated because it's deeper, complicated ligature, more complicated. This is because we have to add another structure. First of all, drawing here the nerve number 12, it passes also, forming an arch through the space, passing up and then running to the base of tongue. So please, this is nerve number 12, maybe 12. We can add number 12. Don't forget, here lies in the position lingual, definitely, with the ganglion, submandibular ganglion, as we said. Again, it runs to the tongue. And the nerve number 12 runs together with the vein, accompanying vein. We call it vena comitans. So we are drawing also the vein. So the vein here is the vena comitans. Comitans nervi hypoglossy. Nerve. So we see all the structures, and then if we look at the arch of the hypoglossus, and then these lines, so this is roughly trigon, depending at the position of the stylohyoid, and then the second one, just labeling it, we call it a Pirogov, Pirogov's trigon. In fact, it's not trigon. So in P, so we could say that this is the B, Becklard, and P, Pirogov. So B and P, more complicated. So in P, Pirogov's triangle, Pirogov's triangle, or trigon, both terms are used. You see, so very important for dentistry to know that in case of bleeding, we can compress, we can dissect and make ligature of the artery stylohyoid. Good. So we know everything which was clarified. Number 4 is the carotid trigon. Number 4. Using red, yes, using red, carotid trigon, triangle. Carotid trigon is the trigon which which contains many structures. Excellent diagrams are found in all the books. So we will not draw that trigon completely because this would take much more time. By the way, 2 or 3 regions should be sent to you because this is necessary to complete the maximum, but not all, because there are so many regions on the neck, and I don't want to eliminate anyone. Carotid trigon is bounded by first of all diagram, simple drawing from one book for dentistry. In Czech, we see the boundaries: sternocleidomastoid posteriorly, omohyoid anteriorly, and then digastric again superiorly. In key position are the vein, internal jugular vein in blue, more lateral. On its posterior lateral margin descend the chain of the lymph nodes. We call them nodi lymphoidei, lymphatic nodes, cervical, deep cervical lymph nodes. Then follows on the medial position the common carotid. At this level is the bifurcation C3, C4 into the external ventrally and in dorsally situated. The first ever branch of the external is the superior thyroid. Then what we see is small branch of the vagus. This is the superior laryngeal nerve. Here in yellow is the hyoid. And then you see also the tributaries and branches. Here is that lingual artery, as you see. We can even draw more like that. This is the lingual. That one is facial, and also hypoglossal arch is seen. So these are the principal structures in their position. So first of all, the boundaries. Maybe that we can make a sketch again. This is even better. This is omohyoid anteriorly, sternocleidomastoid, and posterior digastric. No, easy. So we see the boundaries in one sketch. Concerning the layers show the contents, which is important for us, from of course of high clinical importance. Concerning the layers, number skin is again thin skin, thin. Then number 2 is subcutis. Subcutis again the platysma covers lies in the superficial layer, platysma. Then the nerves at the same level or layer is the transverse cervical from the cervical plexus. Then external jugular vein, as usually with plus superficial is followed by superficial cervical lymph nodes, correct. Then on the next page, no, in the same page, but we have to complete. Then follows the superficial or investing superficial fascia, investing fascia. The fascia forms the fascia knot. That one not. Investing fascia. Then follows the deep fascia. No, better subcutis than fascia. Correct. Number 4. Then follows the tracheal fascia, and that plus carotid sheath. We have already drawn carotid sheath. We will not repeat it. No need. Carotid sheath, which is a fragment of that. Then must be the common carotid. We would say carotid arteries. Then on the superficial fascia plus ansa cervicalis, could be cervicalis superficialis, could be, but usually it's in the submandibular trigone, so then maybe not necessary to mention it will create, it could create for you syndrome, because there are some varieties, and why we will speak about variants, no need. Fine. Pretracheal fascia plus carotid sheath, correct. Carotid arteries plus sinus plus carotid body. Again, everything was completed. Then number 6 is the cranial nerve number 10. 10 plus superior laryngeal nerve, superlaryngeal nerve. Then cranial nerve number. No, this is more superficial, cranial number 12. So please leave it, but just put number 6, and this is number 7, please. Cranial number 12 plus vena comitans are more superficial than vagus comitans, because it's seen. Yes. And then what else? Number 7, the deepest structure is the sympathetic trunk, and sympathetic trunk is the deepest structure, lies within the prevertebral vertebral fascia, duplication of the fascia. Finished. And then the very last text. So maybe I could send you the picture of this area, or just to know that you can find it in the atlases. Why we speak about the carotid trigone? Why so important is the carotid trigone of the high clinical importance? Concerning the, I would say maybe on the next page, yes, clinically, notes, or clinically, correct, clinically. It's important, the region is very important. Number 1 is the pulsation, so we can feel, or pulsation can be felt, pulsation of carotids, because this is plural, fine. And also plus ligature of carotid, of external carotid. Take care, because internal carotid artery supplies the brain. So this is another story. Then number 2, important palpation. We can palpation of lymph nodes. Yes, in some cases the lymph nodes become enlarged by some infections, by tumors, and so. Number 3, pulsation, not the other ones. We mentioned pulsation and ligation both together. This is good. Then important is the position and course of the cranial nerve number 10. We know that it contains parasympathetic fibers. I would add parasympathetic fibers to heart. We know that the parasympathetic fibers decrease the pulsation, or the action of the heart. Sympathetic increases the action of the heart, while the parasympathetic acts in the opposite direction. So if we compress the parasympathetic fibers, that means the vagus, we can slow the heartbeat, right? So to heart, quite clear. Number 4 is the fact that from this carotid trigone fall the infection. So spread of infection to lower position caudally to superior mediastinum. We will speak about the mediastinum in the next week. In the next week, together with the other topics concerning the topography of the thorax, of part of the thorax. Fine. Then the number 5. No, I would say that exact knowledge of the course and position. Just course is better. Of exact knowledge of course of the recurrent laryngeal nerve from vagus, we said, from vagus, which supplies laryngeal muscles, majority of laryngeal muscles like that, is important. So is very important important in the thyroid gland surgery. The surgery is pointed with the, I would just say, struma or goiter. Don't forget, please, that struma can compress the esophagus, it can compress trachea, it can compress also this nerve, so it can compress also soft tissue. So the larger struma can compress and devastate, in fact, the area of the neck. No, and then number 6 would be sympathetic trunk, with the ganglia, trunk with the ganglia. We have discussed the ganglia, the cervical ganglia, at the beginning of the lecture. Is not necessary to add anything else. So this is region number 4, the carotid trigone, and I mean that we are at the end, just the next one. Because muscular homotrachea anterior we already mentioned, so that the 2 last regions I will send them to you definitely. If the carotid trigone was number, I'm just looking, this number 4, the number 5 would be the lateral region, lateral cervical, and I will send you the lateral cervical region and scapulovertebral 2 last areas as handout by email. So lateral, the title just lateral cervical region will be sent, or trigone also would be together with the last one. With another one. There's also sternocleidomastoid, but this is very simple, and scapulovertebral will be sent. So this text will be sent completely to you. Thank you for attention, and looking forward to see. Better to hear, or even better to be sure that you will also attend the lecture the next week. Thank you, and bye-bye.